the new approaches to melanoma care, tumor-infiltrating lymphocyte TIL therapy, which I've heard a lot about. Dr. Doolittle has been very excited about this new treatment approach, and I'm sure Dr. Doolittle and Dr. Selby will be very excited to discuss it. Just a reminder, if you want to get CE credits, you do need to change your Zoom name because we record who attends by the Zoom link. So your full name and organization. I need to update mine to the organization. And this shows you how. Probably everybody knows how to rename now in Zoom. And if you don't, ask your children or grandchildren or your neighbor. They'll tell you. For disclosures, the presenters report no relationships. And I had one presentation honorarium that I shared. Objectives are described indications for consideration of TIL therapy and identified anatomical considerations for successful TIL procurement. CMEs, CNEs are available. You can either take a picture of our QR code so that you can get straight to EADS, or if you haven't downloaded EADS onto your cell phone, that's the easiest way. And if you have, just put in the 86 task into EADS for what you're attending. And you can do that all along. You will need to complete a evaluation at the end for the CE. And I think that's all I have to share.
Perfect. Thank you, Hope. After I do introductions, I will be promptly texting my children to have them come show me how to change my name because this happens every time. I'm Jen McAllister. I'm the Kansas State Chair for the Commission on Cancer. So it's my thrill and privilege to introduce two of my friends, Dr. Luke Selby and Dr. Gary Doolittle. And they're going to present on some really exciting new science. And so thrilled to hear about it. I'll start with Dr. Selby's introduction. He's a board-certified general surgical oncologist and an assistant professor in the Department of Surgery at the University of Kansas Cancer Center. His clinical interests include cutaneous malignancies, soft tissue sarcoma, peritoneal surface malignancies, and gastrointestinal cancers. He's actively involved in research into the genetics behind cancer development and how surgical stress affects the body's ability to detect and fight cancer, and is a member of the editorial board of Surgical Oncology Insights. Congratulations, I didn't know that, Luke. His original research into the effect that general anesthesia has on post-op recovery and long-term cancer outcomes has been funded by The Ohio State University James Cancer Center and the University of Kansas Cancer Center, and has resulted in 2 investigator-initiated randomized clinical trials. A graduate of general surgery residency at the University of Colorado and complex general surgical oncology fellowship at the Ohio State University, Dr. Selby received teaching awards at both institutions. He's a fantastic colleague in the Department of Surgery, and again, thrilled he's here tonight. Dr. Gary Doolittle then is the Capitol Federal Masonic Professor of Medicine in the Division of Oncology at the University of Kansas Medical Center, where he is also the medical director of the Masonic Cancer Alliance, and has been a dedicated member of the cancer team for years at the University of Kansas. He's been a faculty member there for over 30 years and has a subspecialty interested in the treatment of malignant melanoma. He has written many journal articles, books, and book chapters on a range of oncology topics with a major emphasis on telemedicine and cancer care delivery. Dr. Doolittle serves as the contact PI for the KU Cancer Center MCA MU NCORE grant and serves as a co-investigator for the recently awarded Early Therapeutics Cancer Trials Network grant. Both grants were written to extend cancer care clinical trials to the rural sector in the state of Kansas and western Missouri. Dr. Doolittle earned his medical degree from the University of Kansas Medical Center, where he also completed a residency in internal medicine and a fellowship in hematology oncology. So, gentlemen, thank you very much, and I'll turn the floor over to you.
Great. I spoke with Dr. Selby earlier, and I'm going to kind of lead off here, and then he's going to follow in with the surgical, probably the thing that's of greatest interest to this group, really, the surgical piece. Having said that, part of what we wanted to do is give a little bit of background on the treatment of melanoma because it has changed so much, and then really spend the bulk of our conversation around just TIL therapy and this newer approach to the treatment. of melanoma. I think it's particularly important for this group because this is the first solid tumor in which a particular cell therapy approach has come to the clinic as a standard. And it looks like cervical cancer is not too far behind. I know there's a great deal of interest in cell therapy in the lung cancer arena. So I think we're just seeing the tip of the iceberg with in looking at cell therapeutics in the solid tumor arena. There's no question that in the hematologic malignancy arena, there have been great strides in the last decade, and I think we're going to be looking at something very similar in the solid tumor arena in the next decade. Let's see if I can see how to. Actually, Hope, do
You
you
need me to pull up your slides, Dr. Doolittle?
might be better because the way this is going, I'm not sure.
Happy to do that. Just give me a second and I will get those pulled up. All right. Um, can you see them, Dr. Doolittle?
Yeah, we're this is just fine. And then I'm sorry, Hope, but I'm going to
Start here.
ping you every once in a while to advance the slides. I do appreciate this. Yeah, let's go on to the next slide. I think for well over a century, we've known that the immune system plays a big role in the control of cancer, and there are isolated case reports of malignant melanoma, but going clear back to Coley's toxins and stimulating the immune response with bacteria and actually seeing tumors shrink because of that. And there's so much more that our knowledge base has increased so much in the last 10 to 15 years with respect to this cancer cell immune cell interplay, that's really what's allowed us to harness these cells to fight cancer. It's a really basic slide. It's almost, I shouldn't even put it in front of this group, but just to talk about, what we're doing is taking cytotoxic T killer cells and using them to fight melanoma. And we all, I think, remember enough of our basic sciences to know that cytotoxic T cells can kill cancer cells. And we have this subset of memory cells, helper and regulatory T cells, and they all have this interplay that is ongoing that allows the immune response or allows the immune system not to respond. And so I think what's really changed is our ability to sidestep some of the internal control mechanisms so that we can harness those immune cells and have them fight cancer. Also, from a medical oncology perspective, I mean, one of the challenges we've always had is dealing with sanctuary sites and giving chemotherapy. We had some great home runs in the 70s and 80s with acute leukemia, Hodgkin's disease, lymphoma, and using cytotoxics. And I don't need to tell this group, I mean, what we were really doing was giving the patient toxins and hoping that we killed more cancer cells than healthy cells and that the patient survived it. And I'm a medical oncologist actually talking that way, but that is honestly what the approach was. And so much of our focus in the 80s was on cytotoxics and on trying to figure out which drug would work to kill cancer. And in the melanoma space, there was never a chemotherapy regimen that improved overall survival. There were some that actually enabled the cancer to shrink and you may get a response. And I honestly believe there was a subset of patients that had rapidly growing clones that would respond to chemotherapy. And I believe that subset actually did do better with chemotherapy. But if you take all comers, if you took 100 patients and treated them with biochemotherapy, cisplatin, Velban, DTIC, interferon, and IL-2, you did not improve disease-free survival, and the toxicity was really impressive. So really up until the 2000 teens, in the melanoma space, we did not have good treatments. I spent most of my time working as a palliative care physician. We did have the occasional patient that would respond to biochemotherapy. We'd have even fewer patients, though, actually respond to high-dose IL-2. Now, high-dose IL-2, again, really toxic, an intensive care unit, hospital stay, but was the only agent that actually had shown that metastatic disease could be cured, and the cure rate was quite low. And some of the data say 6%. I still have a couple of long-term survivors that were treated with high-dose IL-2, but there was a tremendous amount of toxicity in many patients that went through that regimen that did not benefit from it. So up until 2011, really, there was no decent standard therapy. I guess in medical oncology, we said DTIC was the standard therapy. Response rates were 10%. 1 out of 10 patients would have their cancer shrink. Median survival was 6 to 8 months with that single agent. So it was abysmal. And I think the only reason I stayed with melanoma, I had focused on melanoma in 2004. I think the only reason I stayed with it is I felt good about the palliative care piece of it. And I early on was boarded in palliative medicine. So it was this bridge between the interest I had in palliative medicine and the interest that I had in malignant melanoma. Can we get the next slide, Hope? But then in 2011, the first drug that actually improved overall survival came to the clinic, and that was ipilimumab, or another name for it is Yervoy. And it basically is a drug. You can see the schematic actually, and I don't know if you can see my mouse or not, but CTLA-4 downregulates T cell activity, and ipilimumab was a CTLA-4 blocker. So basically, you were blocking a suppressor, enabling the T cell to become more active. And it was that activated T cell that actually went after malignant melanoma. Huge. I will never forget this. March 25th, 2011, 1300 Central Standard Time, this drug was released. And my phone was ringing off the wall because so many melanoma patients were anticipating this new drug that was supposed to make a huge difference in the clinic. And so it was the first. Also ridiculously expensive when it came out, and that hasn't changed any. But it was the first drug to actually change the national history of melanoma. About 2 years later, nivolumab hit the market, and nivolumab is an anti-PD-1. And if you look at T cells, they elaborate the PD-1 or the programmed cell death receptor. If you block that and keep it from interacting with the PD-L1 of a tumor cell, you wind up with an activated T cell. And once again, that activated T cell is free to go after and bind a melanoma cell. And that was a huge advance as well, because again, you're harnessing the immune system to fight melanoma. So as we always do in cancer, we had single agent activity with IPI, we had single agent activity with nivolumab. And so we combined the two. And just this month at ESMO, the 10-year survival data for the combination of ipilimumab and nivolumab is still holding at about 70%. Now I'm talking about survival data in the metastatic setting, right? 10 years, 70% survival. When I started before immunotherapy, it was a 6 to 8 month median survival with single agent DTIC. So I guess one of the things I really wanted to drive home tonight is we look at metastatic melanoma very differently than we used to. We used to think of it as the proverbial death sentence, and I still deal with that. I know Dr. Selby still deals with that, where we think, the patients come in and they're like completely shattered because they have this completely incurable cancer. And that's really changed with the advent of immunotherapy. So what comes next? If it works well in the metastatic setting, we move it to the adjuvant setting. So high-risk melanoma patients, those that are lymph node positive, or stage 4 patients that go to you and you render them surgically disease-free, we treat with adjuvant therapy. And the first data that came out was adjuvant Yervoy. It was really toxic. It did improve disease-free survival, but was so toxic, it quickly was replaced by adjuvant nivolumab and adjuvant pembrolizumab, also an anti-PD-1. If you look at metastatic patients that are treated with Yervoy as a single agent, or ipilimumab as a single agent, response rates are relatively low, and 5-year survival rates are on the order of 10 to 15%. If you look at single agent anti-PD-1s, the 5-year survival rate's 30%. And then I just told you the 10-year survival rate of the combination looks like it's 70%. So that's a combination that as a medical oncologist, we're going to have trouble getting away from in the metastatic setting. If we look at adjuvant therapy, there's an indication for stage 2B through stage 4 that are surgically disease-free. And I really think it's important. I think the dermatology community is really coming around to the stage 2 patients, but Dr. Selby and I are constantly out there beating the drum for adjuvant therapy. Selby's the only surgeon I've ever worked with that likes immunotherapy better than I do. I don't even know how to handle it, really, because he wants to do immunotherapy when I want to do surgery. It's this complete reversal of roles, I think. But the point for you all is even earlier stage patients, stage 2B, stage 2C, have an indication for adjuvant immunotherapy. And then most recently, the push toward neoadjuvant therapy. And I think, in the cancer space, surgeons get this because even as a medical student, when I was going through, the care of the surgical patient was multidisciplinary. And that it was held true then, and it's never been more true today. Working in tandem with medical oncology, radiation oncology, pathology, interventional radiology, I mean, it really have to have an opportunity to weigh in, because if particularly in the neoadjuvant space, you all are going to be seeing these patients before I do. And when I want to give immunotherapy prior to surgery, if we don't all work back and forth carefully with this, that's not going to happen. And let's if we can go to the next slide, Hope. Just wanted to quickly put a plug in for neoadjuvant therapy or therapy prior to surgery. And our center was part of SWOG 1801. It's a neoadjuvant trial that basically compared patients that had, don't you love this slide? Could I put more words on the slide? It was basically patients that were either given had surgery up front, followed by adjuvant therapy, versus stage 3 patients that had neoadjuvant immunotherapy, surgery, and then adjuvant immunotherapy. These patients were either stage 3 to stage 4C. So if they had stage 4 disease and you said they were surgically resectable to the point where we could make them disease-free, they were candidates for this trial. If they went on the study, they had 3 doses of pembrolizumab, then surgery, then an additional 15 doses of adjuvant pembrolizumab, or they were randomized to have surgery up front, followed by 18 doses of pembrolizumab. Can we go to the next slide? And the major outcome in all of this was patients did much better if they had neoadjuvant therapy. And that's why it's just so important for us as an oncology community to be working back and forth. These were patients that had surgical disease in the stage 4 setting or palpable adenopathy. They presented with clinically palpable stage 3 disease. And the disease-free survival curves were so remarkable that the trial was closed early. And that's been a good thing and a bad thing. It closed early. That's good because the event-free survival or the disease-free survival was so completely different in those that had therapy up front that we ethically had to stop. But it wasn't a registration trial. And because of that, there's been this controversy over whether we should actually be whether insurance companies should actually pay for this and whether we should actually be treating neoadjuvantly. Having said that, both Luke and I have agreed if they ever try to extend this trial, we're not going to participate because I wouldn't want a family member to have surgery up front. I would much rather have them have neoadjuvant therapy, and for the reasons that we've discussed. The theory is when you take out a lymph node that is rich in melanoma cells, but it's also rich in T cells that are melanoma specific for that patient. And when you give immunotherapy up front, you are increasing, those cells, you're activating those cells that have melanoma specific to that patient activity, but you're also increasing that cell pool by leaving the tumor intact and then removing it and coming back with adjuvant therapy. Could we get to the next slide, Hope? And this was reinforced. This trial was just presented at ASCO, and I'm not gonna go through it in a tremendous amount of detail. It's a little different twist in that the two drugs that we use in the metastatic setting, nivolumab and ipilimumab, were given to the patient neoadjuvantly. So it was a phase 3 trial. Patients again had macroscopic palpable nodes, and they received either 2 cycles of neoadjuvant ipilimumab and nivolumab followed by surgery, or they had surgery up front. Then the really provocative or interesting part of this trial is once they took a look at the pathology, they classified patients as either having a major clinical response or a partial clinical response or basically no response. And they're looking at tumor cell kill. Subsequent to looking at the pathology, if the patient had a major clinical response, they didn't give adjuvant therapy at all. If they had a partial clinical response or very little response, those patients went on to adjuvant therapy. And as you can imagine, the upshot was patients that had neoadjuvant therapy and a major clinical response did better. If we look at the neoadjuvant group, just 2 cycles of ipi-nivo resulted in a 60% major pathologic response, 8% partial response, and 26% no response. Can we go to the next slide, Hope? And again, the conclusion being neoadjuvant ipi-nivo followed by surgery, and then coming back with adjuvant therapy based on the response that was seen with neoadjuvant ipi-nivo resulted in a longer event-free survival. Here's the rub for me personally. The follow-up for this trial is about a year right now, and it's very hard for me to get away from adjuvant therapy in that setting. All right, so I did this with Luke's permission. Actually, he kind of encouraged me to suck you into the neoadjuvant data before we move on to the TIL therapy thing. And that's why you all came, or why you were interested. But that whole neoadjuvant piece, boy, I have to have a good working relationship with the surgeons out there because y'all are going to see these patients before a medical oncologist is. Can we go to the next slide? So TIL therapy. Even with the, remarkable advances in the treatment of melanoma with immunotherapy, we still have upfront patients that have resistant disease from the time they start with immunotherapy, or we have patients that respond initially that relapse. We're talking about a 10-year survival of 65 to 70%, which is huge. But we still lose a significant number of patients in the metastatic setting, even with our standard therapy. Couple that with the advances that have occurred in the TIL therapy arena. Now we've got a different approach for metastatic patients. And once again, it's multidisciplinary and it requires input from all disciplines as patients work through standard therapy, and then when we don't have a reasonable option, they're a candidate for TIL therapy. TIL therapy, it basically, the schematic on this slide kind of gives you an idea of how it works. Many of you are probably already familiar with it. You remove a part of the patient's tumor, as we talked about in the neoadjuvant setting, that tumor has a bunch of lymphocytes that are infiltrating through it. And again, those are lymphocytes that are directed to that individual's specific melanoma. And we know we're talking about 60, 70, 80, at least antigens present on an individual's melanoma. And part of the challenge we have in the melanoma space that we don't have in the hematologic space is there are so many different antigens to try to direct your therapy toward. That's an advantage for immunotherapy, but it also becomes a disadvantage if you're looking at vaccine type therapy. Okay, so back to TIL, you have to procure the tumor. And this is where Luke and I really work very carefully together. And I'll let him explain a little bit more about his particular approach. But I'm a medical oncologist. The people in my clinic hardly let me, handle scissors, let alone a scalpel, right? So when it comes to tissue procurement, this is where it's really important to have a good working relationship with your surgeon, because the surgeon has to determine where is the best, the richest source of TIL cells, tumor infiltrating lymphocytes, the easiest approach to those cells, the surgical approach that is least morbid but appropriate for that patient. Once the tumor is extracted, it is then sent to a central lab, and they're grown exogenously, and they're grown literally in the billions. Those come back to the patient and then are infused back to the patient. The idea is you've taken a finite number of immune cells that were part of that tumor, and you've grown them into numbers that hopefully will overwhelm the bulk tumor that is left behind. Can we go to the next slide, Hope? I only threw this slide in to say this is so different from CAR T, right? We are taking the patient's own cells and we are expanding them, over and over and over again, and they're grown in the lab. It takes 22 days from the time the lab receives the tumor from Dr. Selby until the cells are grown to numbers large enough to have a clinical impact. And that's 22 days, right? So CAR T is very different because you take the patient's lymphocytes and they are genetically changed so that a surface receptor that is directed toward a specific cancer antigen is made, till the patient is getting basically their own cells back. And part of the reason I emphasize this is we've learned, even in the 12 patients we've done so far, we've learned that you cannot interchange these terms with patients. And we talk about TIL all the time. They read about TIL all the time, and they go into the hospital and everybody calls them a CAR T patient. So they're just very different procedures, and they're very different indications. The first indication for TIL is melanoma. Can we go to the next slide, Hope? So again, the first study that was done that actually wound up going to the FDA for approval, it took 2.5 years for the FDA to approve this. And it was a very frustrating time because we had been approached 2.5 years ago as a site that would start doing TIL therapy by the company Iovance. And because they were expecting the FDA to approve it in April over 2 years ago, when in fact the FDA approved it February 16th of this year. We had a little bit of a jump on this, on it, so to speak, because we had an IIT that was written by Dr. Mushtaq at our center. Dr. Selby and I are co-PIs on the trial, and basically he developed a regimen that included less chemotherapy for the patient. And hopefully that will still give us the cell response we want with less toxicity to the patient. So let me dive in a little bit more about the process itself. We talked about extraction or excision. Then these cells go and they're expanded. They come, once they're expanded, they're frozen. And Iovance holds them, the company holds them and notifies us that they have adequate cells and they're frozen and they're good to go. It's at that point that we start the preparation, or the other term we have is lymphodepletion. And the idea is giving the patient chemotherapy so that we actually decrease their circulating or their lymphocyte pool. It sounds counterintuitive because what we're trying to do actually is build up their lymphocytes to kill the melanoma, right? Well, the problem is even though these antigenically should be identical to the patient's own lymphocyte pool, when you infuse them, there's a little battle that goes on between the circulating lymphocytes and the TIL cells that you have infused. So for that reason, we lymphodeplete or we prepare the patient with chemotherapy. And this is where Dr. Mushtaq's trial came from. Instead of giving cyclophosphamide and fludarabine in the doses that are listed on the slide, he actually developed a protocol that decreased the doses of both agents. And then at day 42, we're looking at the circulating TIL cells. And our theory is that we're still going to have the same amount of circulating TIL cells with less toxicity. And those data are still coming together. And we don't have data to share with you on that piece at this point. After the lymphodepletion occurs, the patient's admitted to the hospital. By this time, Iovance has shipped the cells to us, and that's a procedure unto itself because it's sent frozen, and it's quite a process getting the cells here. Cells are taken out, they're thawed, and they're infused much like a regular transfusion, and that's on day 1. And either that evening or the next day, we start with high-dose IL-2. IL-2 was the first immunotherapy drug that we had in the clinic. I mentioned when we were talking about standard therapies that high-dose IL-2 actually did affect some cures in the 80s and the 90s in this country, but the percentages were really low. The interesting part about this, if you're into it, is that TIL cell therapy started at the NCI in the 80s and 90s. I sent patients to the NCI for these trials, and I have 2 long-term survivors that went on TIL therapy then. The problem was it took too long to grow the cells. It took like 8 weeks. And what's different now is Iovance has figured out a way to grow these cells in 22 days. For a metastatic melanoma patient, that's still a long time frame, but it's a lot shorter. 3 weeks, we're looking at 3 weeks versus 8 or 10. Patient gets the cells, and then we give them high-dose IL-2. And the high-dose IL-2 is designed to stimulate the TIL cells, both activate them, but also increase their numbers. And we give that in the intensive care unit. High-dose IL-2 is really toxic. It can cause patients to have multi-system toxicity, anything from liver, kidneys, lungs, fluid retention, capillary leak syndrome in the lungs. I should have said CNS toxicity. So we have to monitor these patients really carefully, and they get 6 doses in the intensive care unit. Once the 6 doses have been infused, they get transferred to the floor. Meanwhile, the Cytoxan and fludarabine have dropped their counts to nil, and the patients stay in the hospital until their counts recover. Can we have the next slide, please? So what was the trial that actually brought this to the clinic? It was the product is actually called Lifileucel, or the trade name is Antagvi. And it was basically a phase 2 trial, single arm, multi-center, in which 66 patients, it took 66 patients on this trial to actually get this cell therapy approved for melanoma. And as I mentioned, they were treated very much the way I've just described, in which the tumors were harvested, the patients underwent a lymphodepletion regimen, they got their cells and high-dose interleukin-2, and then they were followed based on objective response rate, and then ultimately working towards survival. As I mentioned, 66 patients were part of this study. Can we have the next slide? Response rates, 36%. Okay, so that's not what we want. That's not high enough, right? So a third to a little bit more than a third of our patients are going to have their tumors shrink. 2 of those patients had a complete response. 22 of them had partial responses with a disease control rate of 80%. So no growth or response in 80%. As of the time of the publication, those are the numbers that we've had. Safety profile was what we expect for a patient that's undergoing chemotherapy like they did and undergoing high-dose IL-2. It was the first signal that we had that cellular therapy could actually have an impact in the natural history of metastatic melanoma. What are some of our challenges? These patients have big, bulky disease. If we get them late in their disease trajectory, it's much harder to get them through the whole process and get them to TIL. And when I mean that, and Luke, you may want to talk about just the weeks-long process that goes on prior to actually getting to your part, the procurement piece. But we've just learned a tremendous amount, even with our first 12 patients, and what it takes to make this happen. We are an authorized treatment center for Amtagvi. There's 50 in the country right now. I think it shows tremendous promise. Can we get to the next slide, please? Just the beginning. I mean, there are just so many ways to tweak this to see if we can improve on that 36%. The natural thing to do would be start to try to go upstream, take high-risk patients, go to, well, we have a trial right now, a phase 3 trial that's open for metastatic patients. But you have to really select those patients carefully, because if they have big, bulky disease, trying to get them to TIL is a real challenge if you don't treat with another agent up front. What about tweaking the T cells more? What about we just put a patient on a phase 1 study just yesterday, in which it's a PD-1 knockout study. So there should be no natural way to knock those T cells out, and the T cells should have greater activity against the melanoma. So there's just so much potential with this. What about combination therapy? TIL therapy followed by immune therapy. Immune therapy up front with the idea that you go to TIL. What about tandem TIL? That's what we do. We've done in the hematologic transplant world, where there's 2 TIL cell procedures instead of 1. As it stands now, it's a one and done kind of procedure. Can we go to the next slide? So the impact on practice. I think it's going to be like all other new therapies that come to the clinic. I think we don't know the impact right now. I'd be really happy if heavily pretreated patients, a third of them actually had an improvement in their disease-free, but hopefully overall survival. I think it is a new approach. I think there's less toxicity associated with this regimen than some of the immunotherapy regimens. I talk about Ipi-Nivo and that 10-year survival, but that is a really challenging regimen to get through. And if you look at if you look at one round of Amtagvi like this or lifileucel like this, it's less toxic than some of the immunotherapy regimens that we have. We still need to figure out how to optimize this. I think it's going to go to cervical and lung. We've got a lung trial that's not in process. It's in the process of getting opened. I would love to say we're accruing and we're not yet, but that's next. The timing in between procurement and TIL infusion. What can we use as a bridge? After Dr. Selby does his piece, what can we use a bridge to hold down the melanoma while we're waiting for those cells to grow? And then I think patient selection. What's the optimal patient to go for something like this? Because certainly at the beginning, we were taking all comers, and I think we're learning that there is going to be an optimal patient for this, and it's probably going to be the patient with lower bulk disease, which means we really need to get these patients as soon as it appears that their immunotherapy is no longer containing their disease or controlling their disease. Next question, that should be my question one. And we can hope we can come off sharing thanks for that. And I will turn it over to Dr. Selby. You all know Dr. Selby. He's been here for a couple of years now. I had worked with Josh Mallman for years, and I thought I'm never going to get another partner that I get along with as well with. Selby's New York. I'm Philadelphia. It's a good fit. We work. It works. So anyway, I grew up in Philadelphia, so I get New York, and New York gets Philadelphia. So I'll stop with that and turn it over to Luke.
Yeah. Thanks, Gary. I think I don't have any slides. I'm just going to sort of talk about this, what we've learned as we're developing the TIL program, and sort of surgically what I've learned. The short version from the surgical perspective is we are learning how to do this. There's a group of us that's planning to get together at actually a sarcoma meeting in November. But as you know, in the surg-onc world, lots of people who do melanoma do sarcoma. And it turned out more of us were going to be at the sarcoma meeting in person than at clinical congress in person. So we're getting together then to try and put our heads together and combine all of our institutional series to learn some surgical things. One, I think the most important thing that Dr. Doolittle hinted at, and this applies both as we're learning just how important neoadjuvant immunotherapy is, either in someone who's newly diagnosed if they present with, palpable lymphadenopathy, or if you ignore that it's not technically neoadjuvant, someone who recurs and progresses through immunotherapy, or honestly, even let's say they were stage 1 and stage 2 disease several years ago, now presents with a bulky node. The key in that patient, it used to be excisional biopsy to take it out, and our hematology colleagues always want us to do an excisional biopsy if they're worried someone has lymphoma, if it's easy to get. Yet they are certainly willing to accept a core needle biopsy for diagnosis if the lymphoma tissue is hard to get. And I think we should extend that. The data from SWOG 1801 and the data from NADINA are so powerful for the use of neoadjuvant immunotherapy with the recurrent or metastatic piece in place, that, if someone shows up in your clinic with a funny looking bump under their arm, we should be getting a biopsy, if they're stage 3 melanoma, but if, let's say, they've progressed and they were on single agent pembro or nivolumab, now if they're going to progress to dual agent, having that focus in place for what would essentially be neoadjuvant dual agent immunotherapy is incredibly important. Or if they've progressed through ipi-nivo and ipi-nivo is no longer controlling their disease, we don't know this yet, but it is going to turn out that the sooner we get TIL on board, the better it is. And so if you can prove the recurrence as minimally invasively as possible, and you can leave a really easy TIL procurement site, that's going to end up being what we want. Right now, there's no data that the site of TIL procurement matters. There was preliminary data presented at SSO from secondary analysis from a TIL trial in the Netherlands that looked at the site of TIL procurement, so skin and soft tissue recurrences versus nodal disease versus deeper solid organs. And there's a trend towards improved overall survival and improved disease stability in the TIL specimens that were taken from lymph nodes. And if you think about it, right, this just has to make sense. They were hampered by small numbers, but the whole reason for neoadjuvant immunotherapy is that we're trying to prime the immune system to recognize the melanoma and go kill it. And so it's a little silly to take out the organ of the immune system, the lymph node, before you try and prime the immune system with immunotherapy. Well, if you extend that to TIL, the node that has melanoma in it, probably, centimeter per centimeter, has far more TIL in it than anywhere else. And those are the lymphocytes that are going to be recognizing the melanoma. Obviously, they're losing the battle a little bit. Otherwise, we wouldn't know about the nodal deposit. But they're probably the best site to get from. And so right now, the only principle I have is do as minimally invasive an operation as possible. So if I have the choice between a skin and soft tissue deposit or like a external iliac node, I will take the skin and soft tissue thing. It's a much easier operation. Even though lifileucel is stable, frozen for months, I don't want to be the reason it gets delayed. So I'm going after the least invasive thing where the risk of surgical morbidity is lowest. I suspect as data matures, it's going to turn out that nodes are better than just random subcutaneous deposits that we get in melanoma. And so at that point, that might shift my practice. We have done a couple of XLAPs and non-segmental hepatectomies for TIL, but that has been obviously our last choice. It's better than nothing, but you'd rather not get a partial hepatectomy than get a partial hepatectomy. And then the other thing to talk about is the risk of TILs not growing or the risk of a postoperative complication delaying or preventing TIL procurement. That hasn't happened here yet. The most important piece of that sentence is yet, not that it hasn't happened. It's an inevitability. The major series show, low single-digit rates of not being able to grow TIL, whether it's the commercial series or the academic centers that do this in-house, but it's low single-digit percentages. We are about to have enough experience where a low single-digit percentage thing has a reasonable chance of happening. So when I'm consenting a patient, it's one of the things risk benefits alternatives. It's one of the things I consent them for. And then there are a couple of horror stories that have come out of major centers where someone has been being worked up for TIL and they've had bulky neck disease or bulky axillary disease, and one hand isn't talking to the other, and another surgeon just goes for palliative debulking to get that disease out because it's bothering them, not really, not communicating with the team that's working them up. And this is within the center. The people that have within the surgeon groups that have told these stories. And so, if you have a patient that's, like I said, that's getting worked up for this, it's really best to keep the disease in place and to talk to them about the importance of keeping it in place, because it may be the spot that makes the most sense to get, even if it's bothering them. Timing wise, this is a real process. And so those of you who work with me know that my OR schedule books out a while. We've actually just recently made some progress with Iovance, where we were having some real logistical issues in terms of booking an OR date that worked with a production date. And they have given us several days a month, every month, that if we can find someone who is a candidate for TIL procurement, we can have that date. And if we haven't found them within a couple weeks of it, the date gets released out into the world. But they're finding this is a thing we've been asking for since the very beginning. And they've finally listened to pleas from us and from basically every other center that's doing this, that the logistics of getting a referral from an outside place, getting worked up by medical oncology and the cellular therapy team, and then seeing the surgeon and getting insurance approval and all of that. I mean, all of the surgeons on board know just how hard it is to schedule a combo case with a couple of surgeons. Imagine a combo case, not with me, but with an airplane, because these things have to get on a plane and fly to Philadelphia. And so as we're learning more, we're getting better at the logistics, but probably from the moment someone is referred to KU for TIL, or from the moment Dr. Doolittle says out loud, hey, we should think about TIL in this person, getting them all worked up, getting them medically cleared, getting them to me, getting an OR date, getting the resection, getting the TIL growing, getting the lymphodepletion, getting it infused, and then at least a couple of weeks for it to work. It's probably 2 months from like saying TIL out loud for the first time until the person has circulating TIL that's working, which again just goes back to the importance of thinking about it early and finding these patients like the moment they present with resectable stage 4 disease, after a history of receiving single and dual agent immunotherapy, or the moment dual agent immunotherapy stops controlling their disease. And I think that, Dr. Doolittle and I have talked and sort of posited that in the future, it'll be single agent immunotherapy, dual agent immunotherapy, TIL, kind of as a clear stepwise progression. Like right now, if Dr. Doolittle has someone on single agent immunotherapy and then all with nodal disease, and all of a sudden it grows, or if he has them on single agent immunotherapy, and then he notices a new node is growing, they pretty much instantly go to dual agent. There's not a whole lot of thinking. There's not a whatever, like that's the clear pathway. And the more we've learned about this, the more we've realized that the moment they then dual agent stops controlling it is when we have to start thinking about TIL. And so that's really, from a surgical perspective, I think one of the most important pieces have, like Dr. Doolittle said, having nothing to do with TIL, but reminding people just how powerful neoadjuvant immunotherapy is for stage 3 or even stage 4 immunotherapy. So if it's the person who shows up in your clinic next week, where a primary care doc or someone is asking you to take this thing out, and then we're going to give them some immunotherapy, remind them that really we should be giving them immunotherapy first and then taking it out. And then if that patient has seen several lines of therapy, that's the person we'd really like to get to TIL. Great question, Dr. McAllister. Thank you. I had this in my brain for a thing to say. We need a minimum of 1.5 centimeters squared, so 1.5 centimeters in every direction, of pure tumor, so that the specimens that get sent out have to be essentially, I have a back table like you're preparing a liver or a kidney for transplant. And they have to be trimmed of any fat, any necrotic tissue. If they're really big, we're opening them up and draining out like for lack of a better word, necrotic goo that's in the middle of a lymph node. And so I have done it with specimens smaller than this, but I really like having if we're going after a node on imaging, I really like having it being about 2 by 2 centimeters, because by the time I'm done prosecting it, it's at about 1.5 centimeters. They can be up to 4 by 4 centimeters, which, as you all know, is pretty big. There doesn't seem to be any benefit. Bigger doesn't seem to be better yet, but it will probably end up being better. What we don't know yet, and what this group of surgeons that I alluded to, what we're trying to answer is it better, like, let's say you have 2 nodes that are 1.5 centimeters each. Is it better to take one out and leave one in and just minimize surgical morbidity? Or is it better to get, 3 by 3 instead of 1.5 by 1.5? And we don't know. Yeah, sorry, go ahead, Kelsey.
Hey, are there theories? So like in breast, some of the theories is that, the clones are not always the same in the primary sites, the nodes and the metastatic sites. So are there directives that you guys have as surgeons to take out the site that may be progressing versus a site that's stable, even if it would not be like the most easily to get to site, or is that not yet known within this technology?
So I try and split the difference. If I have, making this up, if you've got a FDG avid spot in your right axilla that's been stable and a spot in your left axilla that's growing, I'm going to go after the left because it's growing, and that suggests to me, that those cells are the ones that are misbehaving. But we don't. It's so new that basically the answer to any question about nuance in terms of surgical selection, honestly, nuance in whether we need to biopsy it. Yeah, there are some people that biopsy everything. There's some people that don't. There's some surgeons who send a little frozen after they get the node out to confirm that there's melanoma there and not just big reactive lymph node. And there's some that don't. But the answer to all of the questions about do we understand the nuance is we don't know yet. And we're all learning. Sorry, go ahead.
No, I was gonna say, did you already say, sorry if I missed it, do you have to hold then the immune therapy before you go to surgery for a certain amount of time? Because that would seem to potentially impact, doesn't matter, you can just keep going on the immune therapy right through perioperative timeframe.
Yeah. So completely different question. There is a little bit of circumstantial evidence that in stage 3 melanoma, you do not need to initiate immunotherapy immediately post-op. There's one paper out of Duke that showed that waiting up to 12 weeks is fine. And in fact, again, stage 3, some people who initiated immunotherapy in the immediate post-op setting actually had higher rates of recurrence. We know surgery results in immune suppression and immune dysregulation. How that impacts immunotherapy, we don't know yet. But in my life, in the patients who are receiving neoadjuvant immunotherapy, whether for stage 3 disease and I'm taking them for a completion dissection, or in patients who are receiving immunotherapy but are progressing and we're taking for TIL, if they're on active therapy, as long as it's not cytotoxic chemo that's going to impact wound healing, Dr. Doolittle has his treatment schedule and I have my OR schedule, and they kind of just lay where they lay. That's another question we're trying to figure out. You can make one argument that stimulating the immune system with immunotherapy a couple days before I go and resect some TIL, maybe those TILs are a little bit more primed to recognize the melanoma than they would have been had they not seen immunotherapy for a couple weeks. But we know immunotherapy hangs around for a long time. Again, the short answer is we don't understand the nuance. And there's going to be a whole lot of retrospective analyses of prospectively maintained databases trying to tease all this stuff out from a treatment perspective, but also from a surgical nuance perspective.
Can you,
What about,
oh, sorry.
sorry, go ahead.
So you mentioned about preparation of the specimen, like getting all the fat and stuff out. Is there additional pathology support that's needed in order to successfully get the tissue on the airplane? Or is it, if it's sent fresh routine and they know how to drive it to the airport, then good to go?
PATH doesn't see it. So we work with the cellular therapy lab, right, Gary?
Yeah, the cell process labs that
yeah.
do, like the people that do pheresis and handle all the products that it gets shipped back. But it's a pretty carefully orchestrated process, wouldn't you say, Dr. Selby? I mean, it's like everybody's real rigid about steps and everything that has to happen to.
We've figured out the timing pretty well. So we page the cell processing lab, as the patient's getting back into the operating room, they show up literally with a cooler, like you used to pack your lunch in. Um, I resect the specimen, I prepare it on the back table. The company sends a storage media that has several different antibiotics. The cell processing lab has prepared that generally the day before or the morning of. They come, I sterilely give it to them, they wrap it up. Because we're making drug, there's a whole bunch of documentation. Like you think, oh, our specimen documentation is hard. This is a whole other thing, but it gets handled by the cell processing techs who pick it up and the circulating nurses. Um, and then we get it off the back table as soon as possible, into the transport media, into 4 degrees as soon as possible, back to the cell therapy lab for some shipping preparation, and then it gets picked up by a courier, brought to the airport, put on a plane. And it's in Philadelphia later that night. I did one of these that the Friday 6 weeks ago when every PC in America was down. I had one of these scheduled, and that was unnecessarily exciting. I called one of our contacts at Iovance and I said, "Hey, are your planes working?" And they hadn't really woken up yet, so they didn't know what I was talking about. And I was like, "You need to turn on the news, and then you need to make some phone calls and tell me if the OR opens back up, if I can do this operation." But we got it out, we got it off, everything worked fine. Iovance really has their has sort of figured out the transportation logistics around this really well. And now that we've figured out the OR scheduling, and like I have 2 Fridays a month that are reserved for KU time on the Iovance schedule. And so if there's someone who's eligible and ready to go, then we're ready to go. And I guess the other thing I would say is the way Dr. Doolittle, the cellular therapy group, and I sort of work this, or at least the way I explain it to the patients, is it's basically entirely up to Dr. Doolittle to decide that conceptually TIL therapy makes sense as the next treatment for someone. And if he doesn't think it makes sense for whatever reason, then we don't do it. Then I don't even know about him. And it's up to the cellular therapy physicians to decide that someone is physiologically and psychologically able to go through lymphodepletion and TIL infusion and high dose IL-2 and all that. And then the flip side of that is I get total veto power over if there's a resectable lesion that I can get. The beauty of what we're doing, because we're really talking about lymph nodes and skin and soft tissue spots as much as anything else, is the physiologic derangement in surgery obviously is not that bad. The 2 patients that we've done hepatectomies on have been, other than their metastatic melanoma, very young and healthy. And so we've, known that they've been able to tolerate a non-segmental hepatectomy and the recovery from that. We haven't had any major surgical complications. We certainly haven't had anyone had to delay their TIL infusion because of a post-op issue. But I see everyone back at about 2 weeks post-op, like we all do. That's in the window where the TIL is being made, and we've all agreed that there's a sort of at least a theoretical go, no go if they have something going on. Again, if you took out a superficial thing and they have a wound infection, well, you can pop it and open it and do local wound care, and they're safe to get everything.
Is there a difference, I guess, for both immune therapy and TIL therapy based on what kind of disease you're dealing with? So based on if it's nodal recurrence, distal metastases, or say like satellite lesions or in-transit metastases? Is there a difference in the biologies of those and what treatment options you would lean toward?
That actually sounds like a Gary question, even though Dr. Selby, who loves immunotherapy, is probably wanting to jump in right now.
Immunotherapy, immunotherapy and statins should just be in the water.
That's just honestly, no. I mean, our clinical approach is the same. What might be a little different, and as painful as it is to me to say this to this group, this is still a surgical disease, right? So one of the things I really work with the fellows on, if you have somebody that has oligometastatic disease, send them to the surgeon. Or if you have somebody that you treat and they get a great response and they have 2 lesions left, make sure you send them to the surgeon, get it, and put them into a remission. But in terms of like the biology of it, we do know that visceral metastases do not do as well. Skin metastatic disease does better. I just don't know the mechanism, Jen. When you asked, I was trying to think of, why is that? But we know, and we knew that with even high dose IL-2, that skin responses were like on the order of 50%. If you had a bunch of skin lesions, but visceral, much less than 20%. They don't know the mechanism. And for immunotherapy, we don't make a decision based on where the disease is. If it's skin, liver, and lung, we give immunotherapy. If it's just lung, we give immunotherapy. It doesn't.
So Gary,
Yeah, I mean,
go ahead.
oh, sorry. Jen, the other thing to remember is the papers showing that Pembro and nivolumab are effective in stage 3 melanoma are published in 2017 and 2018. So this stuff is so new. So like all of these questions, we're only starting to have 5 and 7-ish year routine standard of care with these medications. So, I remember one of the first patients that I had when I was here had a local recurrence, a big sort of in-transit recurrence in her thigh, and then groin and external iliac disease. And so I took her. Gary had given her some neoadjuvant Pembro, and when I took her to the OR, right, we had 3 different specimens. The thigh skin stuff was all completely dead. The external iliac nodes were the groin nodes, the inguinal nodes were like 70-80% treatment response, and the external iliac nodes were like 40% treatment response. And there was something different about that. Now, thinking that we didn't have TIL at that time, thinking to TIL, I don't know whether, what of the sites would it have been good to go after? Is it better to go after and resect the TIL that had killed the melanoma in the thigh? Is it better to go after the TIL that is sort of doing a pretty good job at killing the stuff in the groin? Or is it better to go after the TIL that's struggling against the melanoma in the external iliac basin? And you can make an argument why all 3 of those are right. And so we don't know. We've learned in our experience here, as Dr. Doolittle alluded to, that it's better to put TIL in as soon as possible in patients with disease that isn't really, really rapidly growing, because again, it's 2 months between saying we should do TIL out loud and then having a bunch of cells floating around. But the nuance we don't know yet. We're going to get there, but.
So one of the questions I have, and you may have already addressed it, but is related to CAR T cells and TIL therapy. I know that in the recent news, there's a rare but potential association for blood cancers for those as a secondary malignancy that have received CAR T cells. Are you worried, or do we know if there's a potential risk for the TIL therapy and secondary malignancies?
Yeah, so it'll be interesting to see how those data unfold over time, because I think there's still even everybody's paying close attention to the risk of acute leukemia in the CAR T population, no question about it, right? But trying to figure out mechanistically what the trigger is for that is going to be really important, because it's not necessarily tied to any particular disease type yet. So we're trying to sort that piece out. Separate from that, these are not engineered immune cells. These are cells that really are identical to the patient's own lymphocytes. So one may, may project that it's not going to have that kind of issue because, it's not the same. You haven't changed the patient's lymphocytes. You haven't changed the surface receptors on the lymphocytes. The other thing that we really have to keep in mind with the melanoma patient base, and probably cervical cancer, lung will be different, but the hematologic malignancy patients have had a lot of prior chemotherapy, and that by itself puts you at risk for developing acute leukemia. So how do you tease out, is it really CAR T, or is it CAR T in the face of prior therapy? Are these patients living long enough to get leukemia? There's just so many unanswered questions with that right now. Is it the CAR T that did it, or is it the prior chemotherapy? And these are just how many patients that have had CAR T and they wind up with acute leukemia. So
Yeah, I mean, Hope, it's a little bit of a sarcastic answer, what I'm about to give you, but it's a really important answer. If you survive your TIL therapy for melanoma long enough to get a secondary malignancy, that means you survived your TIL therapy for melanoma. And right now, that's not a year ago. These patients have progressed right now through therapy that 10 years ago was going to revolutionize the treatment of all cancer and cure melanoma. And it's done an amazing job. But we're at like third generation science fiction with a disease that even at this point, the patients we're thinking about with TIL, even as we move it sooner in the treatment paradigm, don't have a 5-year survival outside of TIL therapy in their future. So surviving 5 years to get a secondary malignancy might not be the worst.
Exciting.
The
right.
flip of that is to the chance, because these are not patients that have had prior chemotherapy, the chance of that kind of thing just intuitively seems like it would be less. But what about this unbridled stimulation of the immune system, right? We've got to figure out, are there going to be long-term complications of that? Like what, all these patients going to be horrible arthritic cripples, in a decade after hitting them so hard with these agents? So far, we haven't seen such a signal, but it's always been a worry. Are we going to induce all these different autoimmune-like syndromes in these patients because we keep hitting them with immune cells that contribute to rheumatoid arthritis, inflammatory bowel disease, diabetes? It'll be interesting to see, like, over time, if it isn't leukemia, maybe it'll be something else. Another secondary effect that we hope not to induce.
I have one other question for you guys, and this is related to my role as the MDA executive director. I think TIL therapy is exciting, fascinating, and you also just described getting things onto a plane and working with your cellular therapeutic and so resources that are really challenging in across the state, right? Like not everyone's going to have access to that. So, and yet it could be for lung and it could be for cervical, and it's really great. And my wonder is, how does that work in collaboration with other cancer centers, and how can we make something like that work so that patients who want to be treated at home get care close to home, is it a one time visit or a couple of visits to a center that can do the TIL and then collaboration externally? What about the surgical oncologist the general oncologist? So just kind of talked through what is our future of collaboration, of expanding TIL therapy across the state through collaboration.
Yeah.
I-
I think that the cellular therapy team here has done a pretty good job in terms of building an infrastructure that allows these patients to get home. And I think they really value the role of the referring oncologist, right? I'm not sure about the referring family medicine doc, and I'm not dissing family medicine. I'm just saying if I were a family medicine doc and I was in Ransom, Kansas, and you sent me a CAR T patient, I would want to be very well prepared before that patient winds up on my doorstep, right? And I mean, we even see that in the survivorship world right now about because there are so many cancer survivors, right? I think this is going to be it's going to be easier to collaborate locally because we don't immunosuppress these patients with these agents to the degree that happens with a CAR T protocol. They pretty much, patients pretty much have to stay in the Kansas City area for at least 30 days, if not 42. Because if they get febrile, that's a medical emergency and they need to be on antibiotics within 4 hours. So they pretty much they're pretty rigid about that. But then they're really good about trying to get them back to a referring oncologist. I think we'll be able to in the TIL space because these patients they're fragile, but they're not as fragile because of the TIL therapy. They're going to be fragile because of their metastatic melanoma, but the TIL therapy itself is probably not going to prohibit us from sending these patients home sooner and letting them work. There's nothing like being at home. And we've got a guy now that's out in Ellsworth that maybe I shouldn't have said that. Better be careful. And we also lost a patient to a generalized fungal infection as well out of this group already. So it's not as bad as CAR T, but it's still a high risk kind of procedure that we have to respect.
Yeah, I hope from a surgical perspective, the technical piece is very simple. I mean, it's taking the thing out and then the video to get trained on how to do the prosection is like a 5-minute watch and you think about it. And the first couple I did, I called friends who had done it, not because I needed to, but because, I mean, as everyone knows, when you do something for the first time, you're anxious about it and you want validation that you're thinking about it the right way. But the complicated piece for surgery is all the logistics with the cellular processing lab and getting that and then getting it on a plane. And so, every general surgeon in the state of Kansas is technically capable of doing these operations. But my suspicion, honestly, for Kansas and states like us, it's going to get done at the big academic centers because the big academic centers tend to be near the big airports. And that's the issue, is getting it, in Iovance's case, to Philadelphia. But they'll eventually have another cellular processing lab somewhere. There'll be some other company.
Mm-hmm.
But the principle is going to be the same, which is get it as quickly as possible to the production. And so if you're in, Southwest Kansas, you're either driving to Kansas City or you're driving the cells to Kansas City or you're driving the cells to Denver. So you might as well just skip those scary logistics and get the surgery done close to the airport. But
Or Wichita.
from technical, anyone can do it.
Maybe Wichita too with their regional airport. But their airport, it's probably an international airport.
Part of the challenge now, Hope, too, is it is one company, right? So we literally Luke's schedule is really around the nonstop flight that goes from KCI to Philadelphia. I mean, that's the reality right now. But was said, I mean, more of these centers are going to pop up. They'll build more centers and cell processing centers elsewhere in the country as this expands. So
Thank you. It sounds like it's one of those things that collaboration will be key and something that best care happens anyway, right? It's through collaboration.
tell you what, it is. I don't know if you feel this way, Luke, but it's been like it's a nice way of putting this. It's been a major undertaking pulling all the people together just under one roof to make something like this work. I mean, I've been really impressed with because these are up until this point, these are not traditionally groups that are all working together. And so literally you're bringing 40 people in a room going, this is how we all have to interface to make one procurement work. And I have to admit, the process was much more involved than I had anticipated. Luke would have had a better feel for that maybe just between Ohio State and Colorado, but I was impressed with meeting. I mean, I can't tell you the number of meetings we had before we launched. Get everybody on board.
Yeah, you're making a drug, right? And so the logistics behind making a drug are real. And that's the cognitive piece for Dr. Doolittle figuring out when it makes sense, the cognitive piece for the cellular therapy team, knowing, how to lymphodeplete and how to keep people stable as we're going through the lymphodepletion and as their immune system's recovering, like that's real. Again, to be selfish on a surgical side, the technical piece is very simple. It's the cognitive coordination and, remembering that I'm doing this case. And when I show up to the OR, I have to remember to make sure that the cellular therapy lab is aware and is coming, because how bad would it be to have this thing out and have the people who are supposed to pick it up not pick it up? That's going to be hope. It's honestly like that's the barrier to the resections being able to be done anywhere, is being at an institution that can handle the logistics. The medicine of the resection is very simple. The logistics of the resection are not.
Yeah. And keeping track of
Transportation's not.
where everybody is in the timeline of the 2-month trajectory. It's like Dr. Selby is going to harvest and procure next week. The day after he procures, our patients going on targeted agents to BRAF and trametinib. So our teams are, back and forth. We're literally meeting every Tuesday at 8 now to make sure that something doesn't fall through the cracks on that. Now, I think that'll get better. I think we're also what's appropriately tense, appropriately on point. I don't know what you want to call it, but I think over time this will get better. But right now, well, we got to be really careful.
Great. Any other questions from the audience this evening? Looking at the chat box, I don't see any. I would just personally like to say, thank you both for everything you're doing. Clearly, this is a tremendous amount of work. The science is fascinating. And the amount of time and energy and resources that go into play with this clearly doesn't go unnoticed. So thank you for all your hard work and great care of the patients. Thank you for letting us dupe you both into giving yet another COC quarterly webinar for us. Keep suckering you in. I'm just going to keep doing it. And the talks are always fantastic. So everyone, the EADS codes is to the right in the chat line if you've gotten that, so you can submit for CME credit. A big thank you to the Masonic Cancer Alliance, who helps facilitate CME for all of these meetings. That's very much appreciated. We will send out some update emails with the next quarterly webinar once that has been scheduled. Any other items to clean up for this evening at all? Hope Hope does a great job of managing me, so I had to make sure that I don't need to do anything else. Okay, great. Well, thank you all very much for attending. I hope you enjoyed it. It'll be recorded, so we'll send out links for the recording too if you'd like to watch it afterwards. So thank you all and have a good night.
Thank you much.